Welcome back to Open Med School. Last session we have discussed about the pathophysiology and symptomatology of aortic stenosis. Today I will be discussing assessment of severity and management of aortic stenosis. So the learning objectives are: recognize the clinical features suggestive of significant aortic stenosis, grade the severity using Vmax, gradient and aortic valve area, and understand what is meant by low flow, low gradient aortic stenosis and what are the indications for aortic valve intervention. So first of all, clinical assessment is essential. Symptoms, we have mentioned the severity, the symptoms, remember by SAD, Syncope, Angina and Dyspnoea. These are the classical symptoms of severe aortic stenosis. Again, clinical examination, presence of pulses, parvus et tardus indicates severe aortic stenosis. The BP may be low. Auscultation, you get a harsh ejection systolic murmur radiating to the carotids. Soft A2 or absent A2. These are all evidences of severe aortic stenosis. Assess heart failure symptoms, LV dysfunction, features of pulmonary hypertension. So these are the symptoms by which you assess the severity of aortic stenosis. Now the investigational choice is echocardiography. The core parameters are one of severe aortic stenosis. One is the aortic valve area, less than 1 centimeter square. The transvalvular gradient more than 40 millimeters of mercury, and the Vmax more than 4 meters per second. So you can remember 4, 40 and 1. This indicates severe aortic stenosis, and the normal size of the aortic valve is 3 to 4 centimeters square. In mild aortic stenosis, the area will be more than 1.5 centimeters square. 1 to 1.5 centimeters square means it is moderate, and less than 1 it is severe aortic stenosis. At least you should remember this 4, 40 and 1. And the Doppler echo is used to assess the transthoracic velocity, transaortic velocity, the highest. The details I am not going to discuss. The severity classification is the practical table. Remember this: in the mild aortic stenosis, it is 2 to 3 meters per second. In severe, it is more than 4 meters. And it will be moderate, it is between 3 to 4. So easy to remember. 2 and 4. In severe aortic stenosis, Vmax is 4 meters per second. And very severe, it is more than 5 meters per second. Aortic valve area is something that you should remember. In mild, it is more than 1.5 centimeter. In moderate, it is 1 to 1.5 centimeter square, and severe, it is less than 1 centimeter. And the mean gradient, severe it is more than 40, mild it is less than 20. 20 to 40 will be moderate. So this is a practical table. You can remember, at least remember the valve area and the gradient. When a parameter disagrees, you have to think carefully. So, for example, LV ejection fraction is more than 50, aortic valve area less than 1 centimeter square, Vmax is less than 4, or mean gradient is less than 40 means that is a discordant value. So here we give a dobutamine stressor. That is, valve area wise it is severe, but the Vmax and the gradient not suggestive of a severe aortic stenosis. So this will distinguish true severe from pseudo severe AS. Hope it is clear to you. When the dobutamine is given, contractility increases. If it is actual severe aortic stenosis, the valve area will not increase, but the gradient will increase. Whereas if it is a pseudo severe AS, what will happen? When the pressure increases, the valve area naturally will increase and the gradient will not increase. Now is the paradoxical low flow. The ejection fraction is more than 50. Here, as mentioned, this may be because of the LV hypertrophy producing less N-diastolic volume, and so naturally the ejection fraction will be normal. So here you assess the, suppose the patient is having hypertension, control the hypertension, you assess the measurement and assess the severity again. So the transthoracic echocardiography will identify the morphology, LV size, function and gradients. So ECG can be used to assess the LVH and the strain, contraction abnormalities or atrial fibrillation. Exercise testing may be done in selected asymptomatic patients, but it should be avoided in severe symptomatic case. CT, valve calcium burden to identify the valve anatomy and severity. Cardiac catheterization is reserved for selected discordant or uncertain cases for preventive assessment only. So these are the other additional tests. Now go to the management. Mild and moderate aortic stenosis, clinical surveillance, risk factor management and periodic echocardiography. There is no drug that can reverse aortic stenosis, even though early studies have shown that the statins can decrease the aortic stenosis. Treat hypertension carefully. Contrary to popular belief, aortic stenosis, a good person, a 45 to 60% can have hypertension. Treat them. Manage the underlying coronary disease, heart failure, atrial fibrillation according to standard indications. Severe aortic stenosis with symptoms or LV systolic dysfunction requires valve replacement. So when to interfere in severe aortic stenosis? Symptomatic severe AS, aortic valve replacement. Severe AS with LV ejection fraction less than 50, intervention is generally indicated. Asymptomatic patients may merit earlier intervention when severe AS associated with an abnormal exercise test, markedly elevated biomarkers like BNP, or rapid Vmax progression. The decision should be made by the multidisciplinary team. There are two choices. One is surgical aortic valve replacement versus catheter-based intervention. The choice depends upon age, life expectancy, anatomy, vascular access, etc. TAVR is less invasive compared to surgical aortic valve replacement. So it's a shared decision. So we go to two cases. 68-year-old with exertional dyspnea and angina. Vmax is 4.3, mean gradient is 46, valve area is 0.8. Ejection fraction is 58%. So it's a severe symptomatic aortic stenosis, needs intervention. Refer to 15. 78-year-old with dyspnea, LV ejection fraction is 55%, Vmax is 3.2, gradient is 28, area is 0. So it is a area wise it is severe, good ejection fraction, it's a discordant case. So possibly it is a paradoxical low flow and low gradient severe AS, as explained earlier, because of the severe hypertrophy, end diastolic volume is less, and so naturally the ejection fraction can be normal. So verify the blood pressure, consider CT, calcium assessment, and expert advice. So if the ejection fraction is low, in this case you may go for a dobutamine stress echocardiography. So key take-home messages are: do not grade the AS with the aortic valve area alone. The three core parameters: Vmax, mean gradient, aortic valve area. Always assess the flow and LV ejection fraction when values are discordant. Symptoms with severe aortic stenosis is a major trigger for valve replacement. Low flow, low gradient AS requires structural confirmatory approach. A structured confirmatory approach. Severe AS being considered for intervention should be assessed by multidisciplinary team. Stay tuned for further videos. Thank you.